Neurology Quiz number 105. Describe the clinical features, investigations, and treatment of primary amebic meningoencephalitis or PAM. Amebic encephalitis is a rare and lethal central nervous system infection caused by free-living amoebas. Free-living amoebas are protozoan environmental parasites, not requiring a definitive host, found mainly in freshwater lakes and rivers. There are two types of amebic encephalitis: primary amebic meningoencephalitis or PAM caused by Naeglaria fowleri, and granulomatous amebic encephalitis or GAE caused by Acanthamoeba species like Acanthamoeba culbertsoni. Primary amebic meningoencephalitis. Naeglaria fowleri is found worldwide in freshwater and soil. It is thermophilic and inhabits freshwater bodies of warm water, including lakes, rivers, and hot springs. More than 80% of PAM cases are associated with natural water. It can also inhabit swimming pools and recreational water parks that are inadequately chlorinated. Less than 2% of cases are associated with tap water, including infections via neti pots, which are used for nasal irrigation, geothermal wells, a backyard slip and slide, and ablution. Naeglaria fowleri prefers higher temperatures, and the majority of infections are reported in warmer climates and during the summer months. Most infections in the United States occur in the southern states in July and August. PAM typically occurs in healthy children or young adults with a recent history of swimming in freshwater lakes or pools. Naeglaria fowleri enters through the nasal passage and the cribiform plate. It then migrates to the brain via the olfactory nerves. Initial signs and symptoms include severe frontal headache, fever, nausea, and vomiting. As increased destruction of the brain tissue occurs, signs and symptoms include seizures, altered mental status, hallucinations, and coma. Diagnosis is difficult because the initial signs and symptoms are non-specific and mimic bacterial meningitis. This picture illustrates how the Naeglaria fowleri flagellated trophozoites penetrate through the nasal passage, where they adhere to the olfactory nerves and make their way to the brain through the cribiform plate and the olfactory bulb. Investigations. CSF examination reveals increased neutrophils, elevated protein, and low sugar. Naeglaria fowleri infection is best diagnosed by performing a wet mount of CSF and observing motile trophozoites. The organism does not stain well with gram stain and is best visualized using a right Giemsa stain or a trichrome stain. An acridine orange stain can also be used. The CDC and the Mayo Clinic offer a PCR test for Naeglaria fowleri. Brain imaging findings are non-specific. CT and MRI may be normal early in the disease with evidence of brain edema and basilar meningeal enhancement subsequently. This is a wet mount of the CSF demonstrating two amoebas. This picture on the left shows acridine orange stain of CSF. The amoeba appear orange while the polymorphonuclear leukocytes appear yellow. On the right is a right Giemsa stain of CSF. Amoeba, many highly vacuolated, appear blue. This slide shows a CT with contrast of a 40-year-old man with PAM. It shows a right basal ganglia infarction in the left image and enhancing exudates in the perimesencephalic cistern on the right image. Pathology. The cerebral hemispheres are edematous and swollen. The meninges are diffusely hyperemic with a slight purulent exudate. The cortex contains many focal superficial hemorrhages. The olfactory bulbs exhibit marked involvement with hemorrhage, necrosis, and purulent exudate. Microscopic examination reveals many amoeba in the subarachnoid and perivascular spaces. The cortical gray matter is preferentially involved. Severe involvement occurs in the cerebral hemisphere, cerebellum, brainstem, and upper portions of the spinal cord. Pathologically, PAM is a hemorrhagic necrotizing meningoencephalitis. This slide shows a brain specimen showing the inferior frontal lobes, which demonstrate hemorrhage and purulent subarachnoid exudate from a patient with PAM. Treatment and prognosis. From 1962 to 2020, 151 cases of PAM in the US were reported to the CDC with only 4 survivors, which is a fatality rate of about 97%. About 75% of the diagnoses are post-mortem. Symptoms appear 1 to 9 days after exposure with a median of 5 days, and death occurs within 1 to 18 days with a median of 5 days. If a diagnosis of PAM is being considered, the CDC Emergency Operations Center should be contacted for diagnostic assistance and treatment recommendations. Current treatment recommendations include a combination of amphotericin B, azithromycin, fluconazole, miltefosin, rifampin, and dexamethasone. Miltefosin was introduced as an anti-cancer agent and was later shown to be effective in PAM and GAE. However, it is not widely available in all centers. Granulomatous amebic meningoencephalitis, or GAE. GAE is a subacute to chronic infection of the CNS caused by Acanthamoeba species. Acanthamoeba is found in soil as well as brackish water, sewage, and humidifiers. It occurs when the infective form of Acanthamoeba trophozoite enters the body through the eyes, nasal passages, and respiratory tract or ulcerated skin. It enters the CNS by hematogenous dissemination, leading to abscess and focal granuloma formation. Clinical features are subacute and chronic and include low-grade fever, progressively worsening headache, behavioral abnormalities, visual deficits, and focal neurological findings. Terminal events include seizures and death. Diagnosis requires brain biopsy demonstrating trophozoites and cysts. CSF shows elevated lymphocytes and protein and low glucose. Rarely, the trophozoites may be seen on Guillem's stain. Brain imaging findings are non-specific and include multiple ring-enhancing lesions, meningeal enhancement, and hydrocephalus. The CDC recommends combination treatment with pentamidine, sulfadiazine, flucytosine, and fluconazole.